Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. In today's episode, we explore a challenging case considering long-acting ART in a patient with viremia and past adherence challenges. Joining us to discuss this case are Dr. Aadia Rana, who is Professor of Medicine at University of Alabama in Birmingham, and Dr. Laurence Slama from the Université Paris Hôtel Dieu University Hospital in Paris, France. Follow along with the slides. See the link in the episode show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease podcast channel on your favorite podcast player. So now let's start with Dr. Slama as she introduces this case.
Okay, so let's talk about a case study. There is a person which is 52 years old, living with HIV, and who established care with your clinic about a year ago. He started big FTC TAP, but has not been suppressed with a viral load, HIV viral load at 680 copies per milliliter, with a CD4 count at 195. And this person has been in and out of care with various other clinics over the past 15 years. So we don't have any history of genotypes or documentation, but we just know that he has an history of real PVR use. He is not infected, he was vaccinated, no problem, just diabetes mellitus with a medication treated by semaglutide. So should you consider a long-acting CAP plus RPV?
I think it's a really important question, something for all of us to consider, particularly in the lieu of data that has now been made available to us just even within these past several months. So I think it's a good opportunity for us to review that data and see how we could potentially apply that to this particular patient.
Yeah, because we have the concern of the PVR use in the past, and we don't have any data. So what's going to happen to this person if we are just doing the cabotegravir alone? It's not working. So what do you recommend? Or I have some ideas, and I think we should be cautious with those resistance. But still, there is a lot of data were presented at CRY, and perhaps you can talk about it a little bit to let us know what you think about that.
Absolutely, I'm happy to. So we can start off with the AIDS clinical trial group study, the Latitude study, A5359, which was particularly enrolling people with HIV who had demonstrated a poor virologic response. So that's defined with as somebody who has been prescribed ART, but either has persistent viremia or has been out of care for greater than or equal to 6 months. So they could not have had hepatitis B or any documented integrase resistance or rilpivirine resistance associated mutations. So prior exposure was not an issue. It was the documentation of resistance either at baseline or historically. And in that study, 434 people were screened for enrollment. Participants in this study initially needed to suppress on an oral regimen. And that oral regimen had to contain at least 2 active agents, so either PI or integrase inhibitor regimen. And they could take up to 20 weeks in order to suppress until they were, and then they would be randomized to either continue on their oral agents or then receive monthly cabotegravir and rilpivirine injectable. I will note that during step 1, which was the oral phase of the study, or everybody got the oral agents, participants did receive conditional economic incentives for viremia and also had wraparound services for support. And the study also, at the end of the primary endpoint, which is at the end of step 2, participants can then, if they are eligible, either continue on or cross over to long-acting monthly. And then I'll note in the study design also any participant who receives at least one injection is then followed and then either doesn't continue or is not able to get it commercially available after completing the study is followed for 1 year. And that speaks to, Dr. Slama, what you were saying earlier a little bit, this concern about the emergence of resistance. I will note that about 14% of these participants did have either a history or current injection drug use. And at the time of randomization, so these individuals were eligible, they had achieved that suppression in order to come to step 2. But even then, at the randomization visit, 17% were already viremic again. So really, I think speaking to a population that has a lot of challenges with adherence. And so what did we present at CROI? So what we presented were the results of a planned interim efficacy analysis that was conducted on February 12th by an independent data safety monitoring board. And at that interim efficacy analysis, what was presented to the data safety monitoring board was the primary outcome, which is a regimen failure defined as the earliest confirmed virologic failure or discontinuation during step 2. So using the stringent criteria of the interim efficacy analysis, which was a nominal 98.75% confidence interval, you can see that there were 47 discontinuations either failures or treatment discontinuations in the standard of care arm versus 28 in the long-acting arm. So that was a difference of 14.5%. Importantly, what the DSMB noted was the secondary outcomes, is that when we looked at both virologic failure and treatment-related failure, the differences between the two arms was significant, with it at 18.2% of virologic failure and 16.6% at the treatment-related failure. And so based on these data, the Data Safety Monitoring Board recommended stopping randomization due to the demonstrated superior efficacy of the long-acting in the secondary endpoints, particularly related to the virologic failure. We also have, so that's a randomized clinical trial. We're, of course, awaiting the primary analysis, as that was the interim efficacy analysis, which should be available already in the next several months. But we also have clinical experience data. And so this is data from Ward 86 in San Francisco, California, where they started a demonstration project of long-acting cabotegravir rilpivirine in people who've had challenges with adherence to medication, as well as are currently viremic. And so in this sort of demonstration project, they showed that they initiated long-acting cab and rilpivirine in 59 people who had a viral load greater than 50 copies. So they received it every 4 weeks. Of course, that's something that is, I believe, US unique, that it is available every 4 weeks. And then, but they were switched to every 8 weeks after 3 to 6 months for viral suppression. In Ward 86, they do receive intensive follow-up and support services. They could also be eligible for conditional economic incentives. And this is also, again, I think, reflective of our most challenging population, 44% with unstable housing, 9% unhoused, and some active substance use, primarily meth and cocaine. And as we can see that this demonstrated success. We have 81% who remain on long-acting cab and rilpivirine. And when we look at the viral suppression at week 48, 93% less than 50 copies per ml and 95% less than 200. And these are people who are viremic at the time of initiation. So I think in this setting with distinct wraparound services and monthly, and even with monthly, and starting off with monthly injections, I think that certainly shows a promise to this approach in a challenging population.
But do you think if we move to every other month, the challenge will be greater?
I think that's a good question. And it's something that we saw in Latitude as well, or we considered in Latitude. 93% of the injections on Latitude were on time, which was a little surprising for us, and we hope to tease this out a little bit more in qualitative data, but coming in monthly potentially allows the same challenges that we talk about, allows those to be addressed. And if you're coming in only every other month, will there actually be disengagement? We don't know. In this protocol, they do mention that they give the option of transitioning to every 8 weeks after 3 to 6 months. And I think we look forward to some of that detail. So I think that that's a good question in this population.
Yeah, this is a particular population, but very interesting population because we have some patients like that, and it's very important to just not let people on the back.
That's right.
Yeah.
That's right. That's right.
Yeah. Okay. In France, we don't use the monthly dosage of cabotegravir and rilpivirine. I think it's just in US, right? I'm not sure about that, but however, there is some news about the certain guidelines, right?
That is. So I think based on some of these experiences with Ward 86, and then similarly, there was another cohort of about 12 patients in Mississippi, USA. So also an area that had kind of the epicenter of the HIV epidemic in the US, in the southern US, where I'm also located, showed success in people who were viremic and were initiated on long-acting, a cohort of about 12 patients. So small numbers, but patients who are certainly at risk for progression to advanced disease. And so in March of this year, actually right at the beginning of CROI, IAS USA made recommendations for the use of long-acting in a very particular population. So they define this as people who are unable to take oral ART despite extensive efforts and clinical support. So have demonstrated, so they're not talking about people newly diagnosed who say they can't take medicine. They're talking about people who have clearly failed what is considered wraparound services. They also define it as for people who have a high risk of disease progression. And so this is a fairly strict, definition. CD4 count less than 200 or already have a history of AIDS defining complications or hospitalizations. And without a doubt, demonstrating that they have virus susceptible to both CAB and rilpivirine. The guidelines caution that if applicable, please, refer the patient to services that they may need, because I think like most things, and this is what I try to share when people say, oh, you think that the injection is going to fix it all. I don't actually. It is just like we do with Rapid Start or any of the other interventions that we develop. It's not just the pill or the injection. It's every other thing that you are providing along with that can potentially support it. So if all your site has is the capacity to give the injection, but doesn't have the capacity to provide the additional support that some of these patients may need, then I think you would need to examine that a little bit more carefully, whether this is the right approach at your site. And I know we'll talk about that a little bit later about potential implementation. So, in review, this is that very particular population that made it into these new guidelines.
I'm looking at, I look, it's very important because this is the beginning of a new era and a new way to take care of patients. But I'm not sure about, this is recommendation. This is not mandatory and it's in US. We don't have the AX or French recommendation on that for now. But the CD4 cell count below 200, I think there is another challenge is added to this strategy. And I would say that the important thing is being unable to take oral out and susceptible to CAB and rilpivirine. I won't say, okay, if you have 300 CD4 cell count, I don't think you are out of this kind of strategy because you can fail your treatment with a very low viremia still, going on and on for years. So I think it's still a good strategy for people with higher CD4 cell count than 200. You don't think so?
Dr. Slama, I actually agree with you on that. I think the main point is what you just said, unable or unwilling to take oral ART, and then the persistent viremia. What we have data that shows even at higher CD4 counts, you are at risk for even non-AIDS defining conditions, right? And then in addition to the personal health benefit of being suppressed, there's also the public health benefit of becoming suppressed too.
Right.
And so I'm going to agree with you on that I think these are almost a little too stringent with regards to the second point, and that we should take a more patient-centered approach perhaps in this consideration. These are recommendations, but I think we can take that into consideration. I completely agree with you.
So the other concern for us, and because we already discussed a little bit together, is about having the information of resistance to cabotegravir or rilpivirine in case of switch, for example, in this case study. So are you concerned that this person may have achieved rilpivirine resistance? And would you do genotype testing? Do you do a genotype, proviral genotype testing in US?
We do, not uniformly and not baseline, nothing of that nature. And I think it might be a combination of reviewing when they tell me that they have prior exposure to rilpivirine. What does that exactly mean? And I think I would be more inclined to test for it if, while they are allegedly prescribed rilpivirine, we have demonstrated viremia while on rilpivirine, but we do not at the same time have genotype results that give me assurance that, okay, they were prescribed rilpivirine, but they really weren't taking it, versus they were taking it and were having problems. So it is a bit of a nuanced discussion, especially given it's difficult to interpret those archive genotypes. Would you agree?
Yes, I really agree. It's very difficult, but we try to have some data to figure out if this combination can fit patients. So what do we know for now about the risk factor of virologic failure with this combination of long-acting? So you remember a couple of years ago, we talked about the post-hoc analysis at week 48, the data from the VIV trial, Atlas Player and Atlas 2M, and they look particularly at the participants who had confirmed biologic failure, and they show that having a rilpivirine RAM at baseline or HIV subtype A1, A6, or having a BMI, greater than 30, associate two or at least two risk factors combined could significantly increase the risk of virologic failure. So we were taking this into account, but they expanded the multivariate analysis at week 96 and 152 weeks for Atlas 2M, and they saw that the baseline rilpivirine RAM and the subtype of the HIV are the most significant predictive factors for virologic failure. But we also know that if you have just one risk factor or no risk factor, the risk of failure is really, really low. So let's talk a little bit about this very tricky question of the proviral HIV DNA genotype. This is interesting if we want to obtain some resistance data. For example, in my clinic, I saw a lot of patients who are going like this patient in and out in other clinics, and that we lose data. So we need to figure out, however, what's happening with this person we have in consultation. So the DNA genotype is the sequence mutation in cell-associated proviral DNA, and this genotype can be assessed at any viral load level, including people who are undetectable. So it could be a very interesting exam for this population, which is a big population. But we should be cautious because it's much less sensitive than cumulative RNA genotype, of course. So I see two big uh, uh, results and interest of having a DNA genotype is in people suppressed, of course, because if they're not suppressed, we are going to use the RNA genotype. But to detect the intrinsic mutation, even without exposure to the ARV, and we know we have like 4 to 5% of resistance, intrinsic resistance. And the other point is to detect some acquired mutations after exposure to this or that medication, RV. So, but it's not because it's not here that it doesn't exist in the genotype. So when we look at the concordance between DNA and RNA genotypes, for example, in the study, the GenPro study, we see that even if we know that the 3DC resistance exists on the RNA genotype, just only 26% of the resistance mutation, was found in the DNA genotype. So it's a tool, but it's not a perfect tool. So we need to take it into account, but be cautious. So let's see the guidelines, recommendation on polymeral DNA genotyping. So it can be considered for individuals with suppressed viral load when we want to optimizing ART. But if there is no prior biologic failure or on a first or second regimen, if there is a genotypic results from prior biologic failure, we don't need to have a DNA genotype, and it is unlikely because it's unlikely to provide any valuable information. But for example, in the case of this patient, perhaps it may be useful. I don't know, because we can perhaps show any pre-existing resistance suspected. So we have to interpret results with cautious because we may not detect all drug resistance mutation, even if they exist, and we may identify mutations who are not clinically relevant and consistent with response to treatment. So that is the big question about that. We use it actually in patients when we don't have any information in France, right? But not systematically because it's not recommended and it's a heavy work for the virologist, I think.
Absolutely. And it's very expensive.
Yeah.
For us, it is very expensive. That's another thing. We're very careful in our use of it to try to exactly as some of these guidelines say. And even then, we are very judicious in its use.
Right. But yes, right, you're right. So if we look at what was presented at CROI and which is published this month or last month, so it's the CARES study. It was a study of long-acting cabrylpivirine in a sub-Saharan African population, but using a public health approach. So the multi-center open-label phase 3 non-inferiority study was conducted with no resistance testing prior to enrollment of participants, which was very
I would say bold, maybe bold, a little bold.
Okay, bold. So, but they keep some PBMC stored to do at the conclusion, at the study conclusion, some DNA proviral genotype. And so they enrolled adults who were on a stable ART with undetectable viral load at screening, and of course no HBV infection, no prior treatment failure, but it was just clinical. And they screened 512 participants, either in the standard of care treatment in their region, or to long-acting rilpivirine with or without the lead-in because it was optional. So, and they follow patient with the viral load every 24 weeks, which is very long for people in a trial, but they did it like in a real life. And what they show in this study, which is very interesting, is that they looked at the DNA proviral genotype, there were resistance to rilpivirine, and like 8% of the participants in the CAB rilpivirine group had an intermediate or high level of resistance. And for the cabotegravir resistance, 16%, okay, it's 15 to out to 95 participants, but it's a lot, and the 11% had an intermediate or high level resistance. Okay, so we were like waiting for the results, but they're very good because the efficacy results show a 95% of virologic success in this population. Compared was similar to the standard of care, which is very important. Just only 2 participants had confirmed virologic failure in the long-acting group. One participant was subtype A1. He has no baseline rilpivirine resistance, but potential low cap resistance, but that's it. And he had intermediate rilpivirine and CAB resistance at week 48. The other participants has one virologic failure. It wasn't confirmed because he died, but it wasn't related to HIV, and he was subtype D. He had a lower level of resistance of rilpivirine and no resistance to cabotegravir at baseline. But at week 48, before he died, he had a high level of resistance to both scab and rilpivirine. However, those results in the global health point of view are very good, with the non-inferiority of this strategy compared to the standard of care at week 48. So it's a very important data to discuss, I guess. You don't think so?
I do. And I wanted to ask you, Dr. Slama, actually, how are we interpreting this? So almost 10% of the cohort had baseline high, intermediate or high level rilpivirine resistance archive, right? We were talking about the proviral DNA. And I think that has been a big concern about the use of these agents in areas that have had heavy NNRTI use, that baseline resistance or mutation resistance associated mutations are upwards of 10, 15, even in some areas 25%. And so at the population level, how could we, even in transitioning people, how could we safely transition them, even those without a history of failure, to this? Does this study reassure you that we can do that at the level, or how would you interpret that archive genotype, in this context?
It's very difficult because I say something and I say the opposite with the study. So it's very confusing, but this is for the discussion. I think it's a very tricky discussion and I don't have the answer. Uh, I think in a an individual point of view, it's not the way I will do it.
Hmm.
In a global health point of view, perhaps it's an option, but I will be cautious because this is in a trial, and the message for me, I think the message would not be to say, okay, just put everybody on this drug and we will see what's going to happen, because it's very, very dangerous, because we know that a lot of people are resistant to an NRTI. So, and we want to keep the integrase inhibitor family, to keep it safe.
Yeah, we want to preserve it, right? Yeah.
To preserve it, yes, right, right. This is the way that they did this very interesting study with the lenacapavir. And this is the next step for using two drugs that we are pretty sure that there are few resistance or less resistant than with a higher barrier, genetic barrier. So not like the NNRTI who have a very lower genetic barrier. But this trial in a small subset, not a trial, but this off-label use of cabotegravir plus lenacapavir is in 34 patients is interesting because we discussed previously that there is a lot of NNRTI resistance, in particular in low and middle income countries. So it could be an option for this population to have new treatment with injection, with long-acting treatment, whatever if it's injection or pills. But this is a very interesting way. And in this uh, uh, case series, they show that the most important message is that they had suspected an NRTI mutation, and so using this association put people in virologic success in 94% of them. So, which is a very good result. Of course, we need some studies to confirm, to look at that, to see it in a large group, in a real trial. But I think it's a very interesting subject to discuss too.
I agree. A very provocative, interesting. You're talking about one drug that's being administered every 6 months, another one that I believe they did some every 4 weeks and some every 8 weeks. So, interesting to see how that gets, sort of washed out. But I completely agree, Dr. Slama. A trial is the way to do this. We need these answers, because it's challenging. I recently reviewed a case of a pregnant woman who has extensive NNRTI and is unable to tolerate orals, and would this be a strategy in her? And so I think really important questions to be asked.
And this is also important because we know that the cabotegravir will be or could develop in a longer with an ultra long acting cabotegravir, and it will be, because we saw that I tried to, and it will be very interesting to put this population on long acting treatment. So let's see what we will have in the future.
Absolutely. So let's take it back to our case study. We reviewed the data. We talked about a little bit our thoughts. And so let's take it back to this 52-year-old who's not doing well on oral single fixed dose combination therapy and has that CD4 hovering less than 200 without hepatitis B, and tells us, I have a history of rilpivirine use, but we have no documentation. And his BMI is 20, we will note, and his subtype is B. So we have sort of those factors in our mind when we look back at some of the data we reviewed. But the big one is this history of RPV use. So what would be our next steps? What would what would we consider as you know, an option? Is it an option for him? Is it even in the realm of possibilities for this patient to get injectable cabotegravir?
I think we should consider it. I don't know if we have to put it on, but I think there is a very good reason to, after what we talk about, to think about this option for the patient.
I agree. And I think we do have the guidelines that support that. And this is somebody who's demonstrated challenges with adherence. I think he might be somebody that I'll get a proviral DNA in. He might be someone, but he's also someone that I would ask for fairly close follow-up. And It's interesting to think about, like, at my setting, maybe he would be somebody that I would give monthly injection rather than every other month. And I know in your setting that may not be an option, at least to begin with. So I think some of those nuances are certainly need to be taken into consideration.
Yeah, I agree. I agree. But there is a difference because I don't know if you pay people to be enrolled in clinical trials. Yeah,
We
we don't.
incentivize them for their time. That is what
Okay.
our regulatory bodies have instructed us, is that for the time that they spend with us, we incentivize them for the time. And then procedures, we incentivize them and procedure includes blood draw.
Okay, so we don't. We don't. This is a little biased,
Yeah.
but yes, but this is what it is. But I think because having a very a population with adherence challenges and without any housing coming every month, it's a challenge for us too because we don't give any incentive. You say so. It's a little bit more difficult. However, even if we don't have the authorization for every month, we do it because it could be an option. So it's an option. Yes, yes. Okay, we perhaps gonna conclude. And do you have any take-home messages for us?
So I think that when I'm looking at patients, I think particularly with these new guidelines and some of the data from CROI, I think it comes back to, when we were even developing Latitude study, the goal is to not necessarily develop a drug, but to develop a patient-centered approach, right?
Right.
And that is really the thing that I want to look at. So I think the priority is your conversation with your patient and your client or your client and seeing, sure, sort of medically, is this the right thing? Is the virus susceptible, et cetera. But then also, what else are you able to pair this with? What are the other things that are informing their challenges with adherence? Are you making sure their transportation issues are addressed if possible? Because if you're going to give them injections, the one thing they have to do is come to clinic. And so I think essentially making sure that you're just not giving the injection, that it's everything that's part of it is included. And then I think for those nuanced, you're not sure about their resistance history or exposure, the proviral DNA could be an option, but I think in addition to that, fairly close monitoring and follow-up.
Yeah, you're right. It's very a centered approach for patients. It's very important. I think this is the main point, and it has to be developed for everybody. And it's very important. We started to treat to switch patients who are not undetectable for this option because it helped them to come to discuss with the nurses, to discuss more often with the medical doctor, to discuss about everything going around the care of having long acting. And this is pretty new for us too, for doctors, and it's new for nurses, for example, who are more, taking care of participants, and they see them a lot. So I think this is a part of the success, of the virologic success of our participants. I agree.
Completely. And we look forward to the future, right? With lenacapavir, other agents, all gearing us towards a more patient-centered approach, which I think is really going to be the key to our ultimate goal, which is ending the epidemic.
Yes. Thank you.
Thank you. A pleasure to join you today, Dr. Slama.
It was great. Thank you, Dr. Rana.
Well, thank you so much to Dr. Rana and to Dr. Slama. And thank you to you, our listeners, for joining in. To see more from this program, see the link in the show notes. Thanks so much, and we'll see you on the next podcast soon.